is now mainly on the GCC, axonal layer and optic nerve head. The diagnostics to pick up early changes are now available. With each advancements in the diagnostics, we can detect the preclinical stage. And then let us go through what are all the advancements in the field of the imaging. Coming to the imaging, the current imaging technologies in the glaucoma are the confocal scanning laser ophthalmoscopy, CSLO. That is the Heidelberg HRT uses that technology. Then the scanning laser polarimetry, that GDX uses that technology. And the most widely used is the optical coherence tomography, that is OCT. This is more practical and popular because this can be used in the other retinal and posterior segment diseases, so that it will become more viable, and then this is more useful for the every practitioner. And then this is another retinal thickness analyzer. Out of this, definitely OCT is superior than many of these other technologies. Coming to the, let us today just discuss about the OCT modality. See, coming to the history, OCT was first invented and introduced in 1991. Then clinically first was introduced in 96. Then those days, the initial OCT was the time domain OCT, that is called the TD OCT, till 1999. Then they introduced the Fourier domain OCT, that is the second generation technology that can be implemented in two forms, that is SD OCT, that is spectral OCT, and then the swept source OCT. So the recent advancements in the OCT, the recent technology is the swept source OCT, and SD OCT uses the LCA with the spectrally resolved spectrometer and requires scanning of the reference mirror, whereas swept source OCT or SSOCT popularly called as is the optical frequency domain imaging technology. So this is the overall OCT evolution from the time domain to Fourier domain, from the Fourier domain from the SD OCT to the SSOCT. Before that, the resolution imaging in medical imaging technologies, the resolution is confocal technology have a resolution of up to less than 100 microns, whereas OCT have the resolution up to 100 to 1000 microns. So that is adequate for our retinal analysis. And then the ultrasound, just to have an idea how the difference between the confocal OCT and then the routinely used ultrasound and MRI. Ultrasound is 1 mm to 10 centimeters and MRI is 1 mm to 100 centimeters. So OCT and confocal are like a live biopsies where we can have the micron level analysis. This is the basic principle of the OCT. Then how the backscattered light will be picked up, and then it will be analyzed with a reference image. This is the time domain OCT, and then we have the spectral domain OCT. Then the swept source OCT. Swept source OCT is mainly the narrow band laser that is rapidly swept in time over a broad spectrum bandwidth. And also there are advancements in the analysis. The entire A scan is acquired by a single wavelength, and it will sweep over the full spectrum width of the swept source. So just to have the comparison of all the three types of OCTs, time domain OCT and then the SD OCT, the axial resolution is 10 microns, and then the 8 microns in SD OCT, and then 6 microns in the SS OCT. The another most important thing is the artifacts. The artifacts are very, very less in the SS OCT as well as in the SD OCT. So if you see the images on the right side, the resolution has improved to a great extent. So almost to an high definition imaging. So before going to the images of the SSOCT, just to have a recap of the retinal layers, all the layers. So all these layers can be clearly visualized in the SSOCT. So this is the SSOCT image where you can clearly visualize all the layers. It's like a live biopsy and as good as the textbook image. So in SSOCT, another greatest strength is retinal thickness can be measured from ILM to retinal pigment epithelium, that is entire retina, and also that is the retinal thickness we can measure. And then the choroidal thickness we can measure separately. So that is the choroidal thickness. And then that is the picture. Then the retinal layers can be segmented. So the T-SNIT, all these graphs, and then the separately we can have the retinal nanofiber layer analysis and then the GCL analysis. So this is the main strength of the swept source OCT. So this high definition imaging is only possible with the recent technologies. So all these recent GCC analysis will have the ganglion cell layer GCL plus, that is the thickness between the RNFL to the inner nuclear layer boundary. Because you see these abbreviations in the imaging, so one should be thorough about this. GCL plus means between the RNFL to the inner nuclear layer boundary. That is the GCL plus. And then GCL plus plus, that is between the internal limiting membrane to the inner nuclear boundary. Because these two layers, it will analyze separately, and this is the GCL plus plus. So this will give you more information while analyzing the cases. So with this background, so of the usefulness of the swept source OCT, how we can analyze each layer, and then how we can measure. Let us see the typical case. So this is the case of the glaucoma with the bilateral inferior notch and then the RNFL defect. So one thing everyone should remember, that always there will be, the first thing to happen is the structural change, which we all can easily pick up. Then only the other changes happens. So like typical pathophysiology or the definition of glaucoma, the axonopathy or the obstruction, it starts at the optic nerve head. So there the structural change are the first thing to happen, then followed by the RGC complex and then ganglion cell complex damage. And then the third thing is the functional effect in the fields. So these two are the, if you go by a traditional management, so you will see that is corresponding with the superior arcuate field effects. But whereas in the left eye, the field still the damage was not that much. So in the retinal ganglion cells, so that's why still the damage may be less than 30 to 40%. So that's why we cannot pick up these changes in the visual fields. But if you have the OCT in hand, then in the right eye, so the optic disc analysis, which is corresponding with our clinical finding, and then that is the RNFL defect. Then whereas in the left eye, we can definitely see the RNFL defect and then the inferior notching. That is very well correspond with the imaging of the disc with the OCT. And then the next is the RNFL analysis, which is, I think it's perfectly matched in both the clinical and then the imaging technology. Here comes the difference. If you see the GCC, this is what I was telling you, GCL plus and GCL plus plus. These two are the layers which are separately analyzed. So the first thing, that the changes that can happen in the GCL plus, then GCL plus plus. So we can easily pick up the earliest changes in these imaging technology. So in the right eye, the inferior RNFL defect that is causing the damage in the, so we have the notching, we have the RNFL defect, and then we have the GC ganglion cell complex damage, which is very well picked up, and then that is producing the visual field change, functional visual field. So all the four things were very well corresponded in the right eye. Whereas when it comes to the left eye, so there are disc changes, there are RNFL changes that can be picked up in the imaging, and the next change is the fields it was not there. Then we were blinded whether how much is the ganglion cell damage. So with this imaging, we can see the earliest damage in this ganglion cell complex. So this is the main advancement or the usefulness of the imaging, where this we can call it as a pre-perimetric or the pre-symptomatic disease. So swept source OCT is a reliable and then repeatable investigation. It's useful in the early detection and monitoring of the progression of the glaucoma. Assess OCT with an, actually I have not mentioned two more options or features are there in the assess OCT, where uh, you can use the angiogram facility with the OCT, where the earliest vascular changes that are happening in the glaucoma can be picked up. And then the another is the microperimetry, which Sureka has presented in her case. These two things I purposefully avoided. I don't want to confuse you. Just I want to first tell you about the initial basics, and then so there are two more additional options we can use with the uh, OCT imaging. So the instead of the functional field or the subjective fields, we have the objective analysis of the visual fields also in the microperimetry. So this is the main advancements in the field of imaging and the usefulness of the SOCT. Other investigative methods like confocal and then SLO technologies are also available. They are also equally effective, but OCT is more widely and popularly accepted. Thank you all.
Sir, this is any other topic is there, sir, to discuss?
Yeah, we will have just 5 minutes. Any
Okay.
questions will
Yes.
entertain, and then
Yes.
afterwards we will close down.
Yes. Sir.
You people, if you want to share something, you can share from the company side.
Had a very good presentation by Dr. and back to the coma. Am I audible? Am I audible?
Sir, your voice is breaking. Sir, you have to use headphones. Always headphones. Headphones are the most
So
reliable.
in my but you can talk.
Next time onwards, we will use headphones. I'll request all of you to use headphones. Headphones and then laptop. These are
Hello.
the two must. Here afterwards, we will be spending more time in these technologies only. So it's worth investing on this. Still, it is breaking, sir.
Sir,
Tarkasra garu cheppu.
Sir, is there any specific modality is there for the early detection of the angle closure?
Yes, sir. That is another usefulness of the OCT, which I have not mentioned. That is, we can measure the angle entry, we can measure the opposition with the anterior segment imaging. So with that, that is a more objective way of analyzing the angle entry, and then rather the narrow angle or open angle. Yes, sir. It is there.
Can it usable for choroidal thickness? That is also
Yes.
helpful for detection.
SSOCT,
iris thickness?
Iris thickness, no. Iris thickness, there we need a UBM, but it cannot be used in the iris thickness because it won't penetrate beyond the iris. So that is the main problem.
Perifoveal capillaries?
Yeah, that there is an angio-OCT facility, so we
The
can have
angio-OCT is
the
there.
angio-OCT. So we can incorporate the angio mode in the same subsource OCT, and then where you can have a very good analysis of the vasculature. So there are number of studies. We have actually one more study going on where the earliest vascular changes are capillary dropouts around the optic disc can be visualized in the glaucoma and compared with the non-glaucomatous eyes. So it's a huge topics there per se. So that's why I have not just touched those things. In addition to the RNF disc analysis, RNF analysis, ganglion cell analysis, we can have the microperimetry, we can have the vascular analysis, and then we can also have the, like you said, the angle analysis. So all these things can be done with the OCT.
Thank you.
For advantage of the society, especially
Sir, advantages of OCT?
OCT, especially in high myopia, findings cannot evaluate perfectly.
So your voice is breaking. So there is one so there are few questions. The one question from Dr. Vani: with the strong family history of glaucoma, will you advise SSOCT? See, always I am stressing you once again. The first thing to happen is the structural change. Then next thing to happen is the ganglion cell RGC and the ganglion cell complex. And then the third thing we can pick up in the imaging. And then the fourth thing is the functional defect in the fields. So unless you suspect in the disc, unless you visualize the changes in the disc, there is no point doing SSOCT for all the siblings in a family. So for that matter, any case, just like that for a glaucoma, it's not like an angiogram, cardiac angiogram. Unless you suspect if there are some suspicious changes in the disc, there is no point in advising the SSOCT. I think that is clear, Dr. Vani. And then the Dharmaraju, another question is optic nerve head blood flow evaluation. Yes, angio-OCT, that's what we were discussing, sir. So the capillary dropouts or the percentage of the perfusion can be analyzed in the glaucoma patients. And they have shown that the number of capillaries or the blood perfusion is less in glaucoma when compared with the non-glaucomatous changes. And these changes, the thickness of the capillary plexus. And these changes are one of the earliest changes, even the patient develops the full-blown glaucoma. So that is again another good modality. I think we need to wait for some more time before we get number of studies published and then reviewed. So these are the two questions in the chat box. I think it's already 9:30. Thank you once again. Thank you all for participating. And then Gautam,
Sir,
I thank the
Sir,
Ajanta
last
for.
question. Sir, last
Yeah,
question.
tell me.
Is it that
Yeah,
we
tell
have
me.
to include the OCT in screening programs of glaucoma, sir?
No, screening program, that's what I'm telling you once again. Unless you suspect a disc change, unless there are suspicious changes in the disc, In the screening, we don't get anything. So screening is by visualization of the fundus, and then the IOP measurement, and then the angle closures maybe with the slit lamp, the torchlight examination, and then the pupil reaction.
Okay, sir.
So OCT is
Sir,
only
once
for
there is a change in the disc, means that there is 30% loss of ganglion cells.
No. Disc changes happens much earlier than the first in the axonal change it happens. Then that leads to the reduction in the axonal flow, then causes the damage in the retinal ganglion cells. So we cannot say that already. So like in the typical case which I have shown you, this left eye, there is a notch and then inferior RNFL wedge defect. But if you see the GCC, when compared with the right eye, there's not much. It's very early minimal damage.
Okay.
So they're not at 30% damage in that stage.
Okay. Thank you.
After there is a lot of research on the disc, sir, and the cup.
Yes. Then one more question is every RNFL thinning is a diagnostic of glaucoma? Yes, that is the first possibility to consider in all the RNFL thinning. Whether the thinning is the focal or global, that is the another point you have to consider. If it is global, then glaucoma may not be the first option. If it is focal, definitely glaucoma is the first possibility. Ravi Kumar, I think that clears.
Sir, thinning is usually seen in open angle glaucomas. Angle closure glaucoma is not the best presentation of thinning in the narrow fiber layer.
No, even the case which we presented, it's a diffuse loss and mainly the central loss. That's why
usually central loss will be there. Usually central loss and diffuse. But narrow fiber layer thinning, superior, inferior thinning usually presents with open angle glaucoma.
No, even most of our angle closure glaucomas also
because most of the angle closure glaucomas is sudden exposure, sudden rise of IOP.
Yeah.
While
in sudden rise and yes, acute attacks, it's more of a vascular damage and then paleness of the disc, temporal pallor, rather than the, like you said, instead of the focal RNFL loss.
Sir, what is the role of contrast sensitivity, sir? Contrast sensitivity that have a role?
Yes, contrast sensitivity is lost in some of the glaucoma patients. So that's the functional assessment of the damage. So that is like a fields only. So these are the structural changes what we were discussing. These are the functional changes.
Thank you, sir.
Okay,
Thank you,
thank you all. Then good night. Then
sir,
stay safe.
Sorry to say, sir, I'm just taking 2 minutes of the time. And
sure.
Yes,
you are the main savior for us.
Thanks to President Sir Gopal Raju sir for giving opportunity to be a sponsor in this program today, webinar program. And also thanks to Satyanarayan sir being a secretary of the District Ophthalmology Association. And thanks to also Surekha madam and Dr. Maithili Kulkarni madam taking the session today. And it is a lot of things from the Ajanta Pharma to be all that Dr. audience who will join today's webinar program. And I will take 2 minutes of the time. As you know that Ajanta Pharma is known for the world-class best manufacturer and also market product in ophthalmology as well also cardiology and also that is in pain management and also skin. But thing is that Ajanta Pharma, whatever the particularly in ophthalmology, the 90% product is the first in India that is innovation and launch in India also by Ajanta Pharma in your fraternity. So and out of that is we have recently launched one product that is Maximus Ultra that is first in India you can say, and also that is international third product. And for that reason, Unkar sir,
Yeah.
Yeah, just I
Yeah.
want to take us 2 minutes for to be share the screen regarding that
Sir,
Maximus Ultra.
yes. Sir, I won't be taking much of your time. First of all, I would like to thank each and every doctor present here. Thanks for giving us this opportunity, to host this particular show. And I am Onkar Shetty, I'm marketing manager for this Prisma division. And as Gautam has rightly said, we are, pioneers for many of the ophthalmology products, and Maximus Ultra is the new addition to this uh, first time new product. And sir, in this Maxmoist Ultra, we have come with sodium hyaluronate 0.3%, which no other company has, which is along with trehalose and L-carnitine, sir. And I would like to thank each and every member for delivering a wonderful talk, Dr. Sir Raju sir, in fact Maithili madam and everyone. Thanks for your time and spending your valuable time with us on this digital platform. So what I'm saying is, what I would like to highlight about Maximus Ultra is that it's the first time combination in India, not only in India but across the world with point 0.3 and 3 halos. Now, with 0.3%, one point that I would like to highlight, we were talking about the corneal retention, which plays a very important role when it comes to the dry eye management. With CMC, we have 10 minutes. It's of corneal of the water retention that can be seen. But with Maxmoist Ultra, with this 0.3% concentration, we are talking about more than 4 hours of corneal retention. And there are articles to back up, the claims that we are making. Moreover, sir, the corneal healing which is there because of this longest corneal retention, the healing that happens. There are studies which have proven that the corneal healing with this particular combination, it is almost 97% corneal wound healing, complete wound closure that can be seen with this particular molecule. And further, sir, you as a doctor, as a medical fraternity, are already aware of how what is the role of tree halos in the dry eye management, which has anhydrobiotic property, which reduces the desiccation induced cell death, making its role very very prominent in the dry eye management. So given in this given together the role of the sodium hyaluronate, the role of tree halos and L-carnitine, it makes a perfectly rational combination for you in cases like the pre and the post classic, the corneal lesions, and moderate to severe dry eye cases. More or so the I mean, SOC what we are using, it is safe on the corneal surface. So with these benefits, we have launched this molecule at a very, very economical price. Now, if you see 0.18, which has been introduced in the market not long back, almost 6-7 months back, there are one or two brands that are available, are very costly. They are in excess of 400. But since we are serving, we as an agenda, we believe in serving quality along with economy. We have made sure that we bring this quality to you in a very, very economical price. So which is at just 365 rupees to your patients. So wherever possible, we would sincerely request you to try out this particular combination, this our Maximoist Ultra as a brand, and do let us know about your whenever. Once again, we thank you for your time here. And
Sir,
yes, over to Gautam.
yes, sir. Thank you, sir. Thanks a lot to be
Thank you,
Onkar sir
then.
for to taking this, and Raju sir, and particularly to entire all the
Okay,
doctors.
then. Bye.
Yeah, thank
Bye,
you,
sir.
sir. Thank
Bye
you.
bye.
Good night, sir.
Thank
Thank
Yeah,
you,
you.
sir.
Bye bye.
Thank you once.
thank you.
Good
Thank you.
night. Good night, all of you. Thank
Good
Yeah,
you.
yeah,
night, all
yeah.
of you. Bye.
Yeah.
Good night, Moitli madam.
Bye. Good night.
Yeah, yeah.
ठीक था
ஒரு டெஸ்ட் டீம்ல கொஞ்சம் முன்னாடி இருந்தது.
Begin. Begin. Yeah, begin. Yeah, base begin. You want to base.